seen that people have started to join us. I know a few more will be on their way, as is always the case, but let's get things started. So thank you all so much for joining. It's my great pleasure to introduce Anusha Jose and her colleagues Will and Ben from the AI Quality Community of Practice. Now, I know that Anusha is going to introduce the AI Quality Community of Practice a little bit later on, and I'm hoping that comes with a bit of an explanation for those that aren't aware about what actually a community of practice is. So I'll leave them to explain that. But just a few bits of housekeeping for me before we do kick things off. As you'll have seen, we are recording the session today, and the recording will obviously make available in due course. We also need to do some processing of it to chop out those first few bits, which don't need to be in there. I'm sure a lot of you will have questions for Anusha and the team throughout the talk. So if you do have any questions, feel free to post them at any time, and you can do that using the Q&A function, which is on the bottom of your screen. So if you look towards the bottom of the Zoom window, you'll see a little button saying Q&A. If you click that, it'll open up a question and answer panel. You can pop your questions in there, and then we will be triaging those questions, and we'll come to them at the end of the presentation. And I guess the last thing for me is that we're due to finish at 5 o'clock. So just apologies in advance if we don't have time to get through to your question before the end of the session. But I think that's quite enough for me. So without further ado, it gives me great pleasure to hand over to Anusha to tell us more. So Anusha, the floor is yours.
Thank you, Joe. Thank you for inviting us to this webinar. Like Joe introduced, I'm Anusha Jose from the AI Quality Community of Practice within NHS England. My manager, Adam Byfield, he runs the Community of Practice, and currently we are a 4-member team. Adam could not join us today. He's attending another conference as we speak. So our plan today is to give you an overview of who we are, what we do, and how we do it. Can you go to the next slide? Yeah, thank you. So we are a community of testers and assurers. We are not data scientists, but we have 2 data scientists in our team, that is Ben and Will, who are here with us today. But we actually work very closely with the data scientists within NHS England, and also the academic partners of various universities, etc., to develop the new AI assurance techniques and also share good practice within the with all of the colleagues. The AI assurance techniques that we use are actually based on the current traditional software testing principles. So when we support our colleagues to assure a new AI system, they're already familiar with the techniques and concept, and they can easily adapt them to assure an AI product. Can you go? Yeah. Thank you. So this is a bit of background. This shows us who we were in the past few years and who we are now. We used to be a part of a formal assurance function within NHS Digital, and our team was called Solution Assurance. So this team was assuring all of the NHS Digital softwares. So any new system that goes live used to require the Solution Assurance sign-off. We are actually doing the technical assurance on the product, so that actually checks whether the product meet the requirements that are defined in advance. In 2021, our solution assurance leads realized that a lot of new AI technologies will be coming our way to assure, and we do not have the capability within our team to assure them. So there was a project setup called Instant. Instant stands for Implementing New Solutions to Test and Assure New Technologies. So this was looking at AI assurance so that our SA colleagues can continue their service when a new AI system is coming in. So after the merger of NHS Digital with NHS England, there is not a single function called Solution Assurance anymore. The members of the assurance team are now embedded in various teams. So to communicate between the solution assurance team members and also to share good practice and support each other, a forum was set up called Center of Expertise. The Center of Expertise actually consisting of multiple communities of practice, and AI quality community practice as one of them. Another change that happened after the merger is now, because we are in NHS England, our remit is wider. So as well as the internal NHSE colleagues, now the frontline colleagues can also raise a request asking for support to assure or procure any AI system that they come across. So a quick summary of who we are. We used to be a formal delivery of assurance function, but now we advise on the Assure to multiple teams. So moving on to what we do on our day-to-day basis. So we have two strands. One is the service delivery strand, and the other one is the research strand. The service delivery is when a frontline colleague or somebody within NHS England internal colleague who needs support in either procuring or assuring an AI, when they come to us to support. So they raise a request, and we provide some advice on how to do the assurance. So the type of services that we do, there are four. It's either, it can be either advice on how to do the assurance. It can be some material that helps them assure the AI, or some tools or techniques. Again, these are all helping the people who are doing the assurance to assure a new AI they can use this. Where the types of service requests when we get, there are three different levels of support that we offer. The first one is called guide. This is basically self-service. So anyone who wants to use our tools or materials that is already available, they can look through the documentation and they can assure the system by themselves. So far, this is the least, primarily because people who approach us, it is going to be their first AI project. They don't have the experience or ability to do the assurance by themselves. But in future, our aim is to make this type of assurance the most common. The second type is support, that where we actually directly be involved with the colleagues, step them through the documentation, step them through the tools, and also support the colleagues on any calls with the developers or data scientists or suppliers to understand the technical details, to ask the right question, and probably help them understand the response and challenge them if required. The last type is Assure. This is rare because of two things. One is we don't have the capacity to assure almost every request that we get. And the second thing is, when we do this type of assurance activities, when we actually be involved, is when we get a new request that we have not dealt with before. We have not seen this type of AI before. So we don't have anything off the shelf to provide to the people who needs help. So that's when we actually do this kind of assurance activities. So when we are involved, we can produce the material and subsequently can be used by others. Yeah. So on the research work stream, that is where we look at the developing the tools and techniques that helps assure AI. Again, there are two types. One is internal and the other one is external. The internal research projects are very specific, very focused project, usually to solve any issues or gaps we identify during assuring AI. Usually on the back of a service request, when we try to respond, we realize that there is a gap. External is more academic, a bit more generic on the wider AI assurance issues. So both of these work streams, the service work stream and the research work stream, they are very closely connected to each other. the research project, like I mentioned earlier, usually come on the back of any service request that we receive. And the end product of any research project is usually going back as a tool or a technique or material, something to support the delivery of any service request that we receive. So can you go to the next slide, please? So I was just mentioning on the previous slide that there are 4 types that we do: advice, material, tools, or techniques. An example for the advice is we have a list of questions usually we share with people that either procure the AI, or sometime it might be a project manager who has a team of developers, or a team of suppliers who develop an AI product for them. So these questions will help them ask the right questions to the developers and understand whether that AI model is working for them, or does that deliver what they are expecting the model to do. An example for the material is risk log. So we do risk-based approach, and every time when we do assurance, so we come up with a list of things that could go wrong, and potential mitigation activities that can be planned and or performed on them to lower that risks. Currently, we have some generic risk logs that is based on the types of AI. So projects can use this as a starting point, and then they can build their risk log on top of the initial set of risks that we have developed. An example for the tool development, there is a boundary analyzer that we have developed internally. I was mentioning earlier that our activities, or the assurance approach, is based on the traditional software testing principles. One of them is actually saying that most of the bugs reside around the boundary. So this tool helps to identify the boundary of an image classifier AI. So we can decide, or we can identify what is the point where model changes its decision to yes or no, 1 or 2, whatever it is. So we can do more rigorous testing around that boundary area, and we can be sure about the model performance. And lastly, on techniques, we all know that the behavior of AI is driven by the data, not the code. So we need to analyze the training data for any bias in the data. So currently we do that with the 9 protected characteristics from the Equality Act, and plus the postcode. So if we move on to the examples of research project, we have a literacy bias project that is actually to detect the bias on any of the LLMs on the literacy. This actually came on the back of a service request that we have received. That actually leaves us in a nice place to hand over to Ben and Will. Ben will be explaining in detail what the service request is, what the model does, and Will be covering the research project that we have done on the back of that service request. So over to you, Ben.
Thanks, Anusha. So I'm Ben. I'm a data scientist in the NHS England Central Data Science team. And I've been working on this assurance project for about 2.5 years with the quality community of practice, and before with Instant. So I'm going to discuss an example of how our assurance approach was applied in the past. And this will hopefully illustrate a little bit of the kind of assurance that we can help people to do. This is going to be, we're going to zoom in on one technical example, one part of one sort of investigative bit of work. Hopefully it will illustrate how detailed interrogation of models and systems can bring some clarity to the extent that we can trust these models. It can lead to effective mitigation strategies, and can even discover some faults that developers haven't caught. So this is the example. On the NHS UK website, you can review services from healthcare providers. This allows others to see how well a service has been reviewed, and it gives important feedback back to providers. Now, there's a bunch of moderation rules that your review needs to pass for it to be published. And until recently, this moderation was done by a team of contractors and then an internal team of specialist moderators. This was expensive and it created a bottleneck. NHS UK actually didn't advertise their review service because it would be too difficult to expand. They were already spending too much on moderation. So they enlisted NHS England's data science team to try and create an automatic moderator. This would take the place of those contracted first-line moderators, but they'd keep the second-line specialist moderators in for the trickier cases. So some of the rules that you had to pass were simpler, so regular expression, programmatic sort of solutions to these, and checking for URLs or offensive language. Some rules were more complicated. If the NHS publishes a review with personal information in it, then that could be a data breach. So names and addresses need to be screened out. And that becomes a lot harder if your name is May or June. If in your review you say something like, "My doctor hit me," that's not a review, that's a complaint, and you should be directed to the complaints department. Yeah. The details of your complaint shouldn't be made public until that complaint's been resolved. So, but that creates an incredibly difficult language task. Determining the difference between a very bad review and a complaint is very hard, even for humans. So the data science team engaged with the AIQ CoP to trial the assurance approach on a subset of their rules. They gave us some of the tricky ones to have a look at. We formed our assurance approach around a standard risk log that we built for natural language processing models. We then, this formed some lines of questioning, and we've had a few interviews with the developers. And from there, we added to the risk log where we needed more detail or whether other parts of the system that weren't captured. Off the back of that, we devised a number of tests to identify the likelihood of these risks and to suggest some mitigations. It was at this stage we were able to capture some of the priorities of the team on what outcomes they considered more risky. And this would differ from rule to rule. So from certain rule breaks, they were more worried about rejecting good reviews, and others, they were more worried about publishing bad reviews. Our risk log tries to ask questions at every part of the model development process and for every feature. So right from development all the way into continual monitoring and drift detection plans. They've been developed with our friends at the National Innovation Centre for Data, and we continually update them with new risks that we come across. One thing we've learned over time is that machine learning systems can be very brittle. They aim to generalize within the bounds of what they've been trained on, but often an effect can be observed that a small change in the input data or the environment can cause a large performance shift. If you imagine a medical imaging system trained and performing well on certain hardware, sometimes they're found to be completely useless if you've got a different set of imaging hardware. Machine learning models are mathematical systems, and they often require the inputs to be of a standard size in order for the maths to work. It needs to be the right number of dimensions. And so often pre-processing steps will normalize an input to get it into the right shape to go into the model. For example, ChatGPT, or at least the free version of ChatGPT, always expects a sort of 4,000 word input, 4,096 token input. And so if you write a message that's shorter than that, it will pad that message up to 4,000 tokens with some blank words that you won't see. And those are then ignored by the later processors, but it always wants something to be the right size. If your input's longer in ChatGPT, then you might have seen it sometimes where it says, "Oh, your message is too long. I'm not going to allow you to do that." Or sometimes it might trim. If you've had a long chat with ChatGPT, it might be trimming the top of your chat, and it'll just be the latest bits that will be included. Or sometimes it might trim the last thing that you said. Obviously, there'll be different effects with that kind of thing. So back to our system, our risk log was systematically asking these basic questions about every step of data development, but also for each task. So for pre-processing, we would ask about pre-processing in training, pre-processing in the testing phase, pre-processing in the live phase. We talk about how pre-processing would continue further on and how it might be monitored. And we'd start to check if anything has changed in those different stages and see if that introduces risk. So in the case of the review auto-moderation team, the team told us that the review was first encoded using an off-the-shelf model. You don't really need to know how this works. It turns the words into numbers so that the machines can process it. But when we looked at the specs of this encoder, we noticed that it had a size limit of 512 tokens, basically 512 words. With that discovery, we suddenly had an investigation to do. We could devise a number of tests and a number of further questions. Reviews, as submitted on the website, could be 3,000 characters. So was it possible to submit a review that was longer than the encoder word limit, but shorter than the review limit? Well, it turns out it was. The average word length in English is 4.7 characters. It's an interesting fact I learned on this project. And so it's very possible to have a review that would fit this and then would fall off the end of the encoder. What was the behavior there? What would happen in that case? We discovered through testing that the encoder just trimmed the review. So it just didn't include anything after the token limit. You can see I'm sort of representing this here. So anything that you put in after a certain token limit would just not go through the rules, and everything would pass, which was not good. We could create reviews that would break every single rule on the moderation list. We could fit all kinds of data breaches and things through, as long as we put them in that little space after the encoder limit, but before the character limit. So what's the risk there? Well, clearly the system was open to abuse from malicious actors, but we also surmised that even non-malicious users could accidentally avoid using the rules if they just wrote a really long review, especially if they're signing things off at the end. Anyone who writes a review that's longer than 3,000 characters as well would probably trim their review down until it just hit the limit. And so there would always be stuff in that space. So there's some risk there. And the key here is that we were able to show that risk to the team. We were able to describe that risk to the team, and then they could deal with it how they wanted to deal with it. With respect to assurance, we were able to say, well, this system can be assured for reviews that are under the 512 token limit, but not assured for longer reviews, where there's an increased likelihood of failure. So what were some of the outcomes of this? Well, we were able to supply them with this dynamic assurance criteria that described the limits of the assurance, where the models were assured, where the models weren't assured. And we were able to offer them some mitigation strategies. There's a few ways of fixing this bug, and we threw them at them. But we also said you might want to monitor how often reviews are particularly long, because that would affect the likelihood of this risk occurring. In the end, they did fix it. That's why I'm telling you about it. So what am I trying to say here? A thing to notice about this approach, there's a combination of the robust practice of assurance that's been tested for years and years and years, of being systematic about looking at each part of the model, combined with the domain knowledge of data science and AI, and to be able to know what questions to ask to which bits of the system and where there's particular risk. It's important to notice that there can be a difference between the system on paper and in practice. This is always the case, and I worry when systems are only assured by looking at their spec on paper, or when they're regulated by only looking at their spec on paper, because there can be a difference when they're implemented into a particular place. This risk is amplified with AI because AI is particularly sensitive to its environment and how it's a small change in the input can cause a big change in the performance. And also on this particular example, I wanted to highlight how we were able to have a really collaborative approach, which was aided by transparency. And we're very aware in the team that this just isn't always the case. I mean, we were working with our friends here that had built this model, our friends and colleagues. And so they were incredibly transparent about their methods and how they built it. And that allowed us to ask some of the difficult questions, which you can't always ask when things are opaque or abstracted. But that collaborative approach allowed us both to work together towards a safer model, a safer system, and a better one. I'm going to hand over to Will now, who's going to dive even deeper into some of our more experimental assurance methods.
Great, amazing. Thank you very much, Ben. So I'm Will Poulett. I'm also a data scientist in the NHS England Central Data Science team, and I've been working with Instant and then AIQ CoP for about a year and a half. So I'm going to talk to you about test data generation, how we used it to analyze each rule. So I'm going to give the same example and talk about the same project that Ben has just discussed, and then how we reported these findings back to the developers. So to investigate all of the rules that we'd been asked to assure, we needed to generate some synthetic reviews. And we did this by creating a pipeline with Python, which used a large language model. In this case, it was GPT 3.5 Turbo. This powered ChatGPT about a year ago. And we use prompt engineering to turn a data frame of scenarios that we'd created into a list of synthetic reviews that we could then use to evaluate each of the rules. Something that I quite like to bring up here is that this is a really nice example of AIQ CoP bridging the gap between data science and technical assurance. Here we're using generative AI to create synthetic data, but creating synthetic data for kind of traditional code with if and else statements and assuring that is something that technical assurance have been doing for years and years. Now, on the right-hand side, you can see a simplified example of how we turned one row in a data frame into a review. So you can see on this row, there are multiple columns. The first one is whether or not we want the review to be a complaint. The second one is whether we want negation. So in particular, this is negative words. So I will not do this, I won't do that, etc. We also had the power to put in values we wanted the review to include. So in this case, we've put MP. And when there might be some confusion as to exactly what this value means, there's the ability to put in some context. I won't read that bit out. I'm sure we all know what an MP is. So yeah, once we had this row, we designed a prompt which this could be fed into. And this prompt was then put into a large language model, so GPT 3.5 Turbo. This all happened and we ended up with a review, and you can see an example review at the bottom. So I recently had a terrible experience with my GP, so serious that I feel the need to write to my local GP, etc. MP, sorry. We did this 400 times, or approximately 400 times for each rule that we were asked to assure. So we had a lot of synthetic reviews that we were using. Can I have the next slide, please, Ben? Perfect. So we'd noticed that it was really important that we manually labeled each review. So this was 400 reviews and we decided to manually label all of them. The reasons for doing this are as followed. LLMs are not perfect at following instructions. That's true now with more modern LLMs, but it was particularly true for GPT 3.5. It just doesn't always do entirely what you want it to do. There were many reviews as well that we intentionally made quite edge case scenarios. We really wanted to kind of narrow down to find out where the model is changing its mind, what features within a review might make the model classify it slightly differently. And this made it hard for us to classify it or label it, let alone a large language model. And finally, we also occasionally wrote our own edge case reviews, which we then needed to label. This happened often after we'd already done the first test with synthetic reviews, and we kind of found a few examples where we thought, this needs some further investigation. So we'd write our own edge case reviews and then label them. So to do this, Ben, Anusha, and I, we would each label the reviews and we would compare where we disagreed. But we did put a lot of thought and a lot of time into trying to make sure our labels were as accurate as possible. So we had various meetings and emails with experts. This was the internal team of expert moderators that Ben has already mentioned. And we kind of tried to make sure that our labels were perfect. And we also used them to fine tune our prompt to try and make sure our reviews were as realistic as they could be. On the right-hand side, you'll see a confusion matrix, and this is comparing how well our labels compared to those that ChatGPT or our large language model produced. You can see in the top left corner, there are all the occasions where we asked the large language model to create something that wasn't a complaint, and we agreed. When we labeled it, we said it wasn't a complaint. In the bottom right, you can see examples where the large language model created a complaint, and again, we agreed. But you can see there are a lot of occasions in the top right and the bottom left corner where we labeled the review differently compared to what we wanted the model to give us. So this kind of stresses just how important it was for us to do the labeling ourselves. So moving on, perfect. We knew that people were going to use this tool or leave reviews where they have low English proficiency. This could be for a multitude of reasons, but one of them, as an example, could be maybe someone's first language wasn't English. Now, in order to make sure that there was no bias towards these individuals with each rule, with the classifier, with the models, we generated 16 unique augmentations for each review. Now, these augmentations were, we included text speech within lots of our reviews. So that includes be right back or GR8 for great. We included misspellings. So this worked we had a large dictionary. And if there was a word in our review, which was also in this dictionary of common misspellings, we would randomly replace this word with another possible misspelling. We also had typos. Typos are different to misspellings because sometimes when you're tapping away, you might just press a random letter. That's what this did. So when we were augmenting something by adding typos, you'd get a random space or a character placed into the review. And we also had one method of augmentation that removed all the punctuation from a review. On the right-hand side in this diagram, you can see an example of a review that includes every single augmentation method. So there's text speech, there's misspelling, there's typos, and there's punctuation. Well, the lack of punctuation, I should say. So yeah, if you read that, you see I had a drally, disappointing experience with the NHS complaints process. It is quite hard to read. But how hard to read is it? Well, we tried to measure this with readability scores. So we used 2 readability scores. So they score how easy to read, how easy to interpret a piece of text is. One of them is called Dale-Chow. This uses a list of common words to derive a score for how readable a piece of text is. And the other one is McAlpine-Eflaw. This uses sentence length, word count, and complex word count to score each augmented review. Now, you might be looking at this methodology and thinking, this probably isn't the perfect way to represent people who aren't very proficient in English. And you might also be thinking this isn't the perfect way of measuring how proficient someone is in English. And this is something we identified at the time. But that being said, we've still got quite a few meaningful results from this methodology. But literacy bias is something that we are continuing to research to this day. Next slide. Oh, thank you. Okay, so I'm going to go through a couple of examples of some of the results we found and fed back to the developers. And the first one is looking at the complaint rule. So our synthetic reviews helped us identify that negation was an issue when detecting complaints. And we did this by using bigram and trigram analysis. So bigrams are kind of 2 words joined together, and trigrams are 3 words joined together. So we can look at which bigrams and trigrams are really common in incorrectly classified reviews. And we found that a lot of bigrams in incorrectly classified reviews had negation in them. And you'll remember that negation is something that we could put in to synthetic reviews with this column here that's circled in red. Now, on the right-hand side is a review that we wrote ourselves once we realized that this was an issue and we wanted to create some more reviews. And I like to point it out because it shows, as Ben mentioned earlier, just how brittle these models can be. So this is a complaint. And if you have a read of it, you can see it's very obviously a complaint. I had a terrible experience with the NHS. The staff were extremely disrespectful, etc. The first time we put this through the model, it was correctly classified as a complaint. But when we added an example of negation and just a small sentence at the end, you can see that suddenly the model decided to change its mind and say this isn't a complaint at all. And I know this is just one example, but I do like it because it just shows large language models and AI can be really brittle. And this is kind of one of the challenges when we're trying to assure things like this. Go to the next slide, please, Ben. Perfect. Okay, so the next thing I want to talk about is our literacy bias exploration. So something we noticed is that across all the rules we assured, there was no strong correlation between the readability score that a review was given and whether or not it was correctly or incorrectly classified. However, we did note that some types of the augmentation we did would increase the likelihood of misclassification. So these graphs are from the names rule in particular. So this rule picks out whether or not someone's name is included in a review. You can see on the left pie chart that the number of incorrect predictions is quite small compared to the right one. This is when reviews aren't augmented. We've done none of our augmentation steps. For reviews that are augmented, you can see that a lot more reviews are incorrectly classified. There's a lot of names that slip through and aren't detected. Now, different augmentation types, we also noticed, had different effects on whether or not something was misclassified. So on the right-hand side, you can see that there was the least amount of incorrect classifications when there was no augmentations applied. We expect that, but also text speech. However, when you look at misspellings, so adding misspellings, adding typos, or removing punctuation, you can see that the number of incorrectly classified names, when the number of times names weren't picked out, increases. So that's quite an interesting finding we found. And we reported all of this back to the developers after we'd done our investigation. That's my section. So back to Anusha.
Thank you, Ben and Will. That actually concludes our presentation today. Just quickly wanted to share some of the contact information here. So in case if anyone wants to contact us. Colleagues within NHS England and across the wider NHS can raise a request through our SharePoint site. So I have added the link to our SharePoint site in the slide deck, but I can also put it in the chat here. There's a button called raise a request on the front page of the SharePoint site. And if anyone finds any issue with the access of the SharePoint site, click on request access and we should be able to sort that out. People outside NHS can contact us through our mailbox. That is nhsdigital.instant@nhs.net. I can put both of them in the chat now. I think now I'm handing back to Joe for the Q&A.
Thank you so much, Anusha, Ben and Will. That was really, really fantastic. Ben, if you wouldn't mind just unsharing slides so we can see each other, if that's okay. Fantastic, thank you. So I know that there must be some questions bubbling along in the background, but I'm going to take the chair's prerogative and ask the first few if that's all right. But as a reminder, if you do have any questions for our speakers today, if you look on the bottom panel of your Zoom platform, you'll see a little button saying Q&A. If you click on that, you'll then open up a window where you can type your questions in and we'll ask those for you. But just to kick things off, we're really fortunate as an incubator community to have members from a really wide variety of professional backgrounds and expertises. And just for those of us that maybe aren't so familiar with the concept of assurance, could you just give a really high-level overview of what assurance is and why it matters in the context of AI health tech?
Okay, yeah. So the assurance, when we are actually technical assurance, like I was mentioning before. It's not just AI. It's a development. And if any old IT system needs a testing against the spec to check whether it is doing what it is supposed to do, we usually have a set of requirement document that checks against the functionality and make sure that nothing wrong with the system that is being developed. So whether we are developing something new or we are buying something off the shelf, we have to do that assurance. During the development, we'll check for any possible bugs within the system that is being developed. If you are buying something off the shelf, we'll do a testing called a deployment testing to make sure the system works in the intended environment properly. This is the traditional, nothing related to AI, but the traditional practice. This is more relevant in AI, especially like one thing that we have noticed is the data that is being trained on decides the way that AI works. if anything, it changes in the intended environment, but a new healthcare setting, it can be absolutely different the way the model behaves. So our kind of assurance comes on top of the regulations. The regulations usually say whether the system or the model developed is fit to sell or fit to use in the wider healthcare setting. And our assurance comes on top that makes sure that actually works on the intended environment. So again, I think I'll try to use the gas cooker analogy. My manager always use the regulations make sure that a particular gas cooker is safe to sell in the market, and the assurance makes sure that if you buy that gas cooker and put it in the kitchen, there is some other additional steps that need to do to perform that is safe to be in that kitchen and to work on, and that is us doing the assurance work. Hopefully that answers.
Yeah, no, great. That's really helpful. Just one quick follow-up from me before we go into some of the audience questions. So how you mentioned that assurance has an overlap with regulation, but how does it overlap with some of the maybe the clinical trials or clinical research that happens in particularly tools that are medical devices?
Okay, yeah. So on the AI as a medical device, there is currently no regulation from MHRA. We know that it is underway, and there is also another team within NHS England that works on NHS's AI policy. Again, that is underway. We have regular catch-up with both the teams, so we are feeding into these kind of regulations. And so when they actually eventually come in to make sure that we are already aligned within the current framework that is in development, and also to make sure that to add on to the point that our strategies, the assurance strategies, definitely do complement on those incoming regulations. Yeah.
Great, thank you. So I'm going to go through a few audience questions now. So the first question, and obviously feel free, any of our speakers, to address any of these questions. So first question from one of our attendees is, what advice do you have for people in the early stages of AI model development to maximise the chance of safe implementation into clinical practice in the future?
Okay, I think I'll just start, and I can see Ben coming and unmuting himself. So one thing that we are trying to push through the regulation is that trying to implement those best practices embedded in the regulation, so that there are a set of questions that we have developed that we usually ask the developers on model choice, model architecture, those kind of things. So if we can embed that into the development practice, we can make sure that we are developing a safer model. So that's one thing. Now I think I'll give it to Ben.
Yeah, I'd totally agree with that. I'd say that yeah, you've mentioned clinical practice in the question, and so that definitely leads you down this medical device route. And yeah, the question sort of isn't settled on where AI becomes a medical device. It's becoming more and more settled in the future. But I guess I'd say don't do less than reading software as a medical device, software and AI as a medical device, and following their roadmap and following everything that MHRA has to say. The couple of things that I'd say you can do more than that are, well, you can engage with someone like the AIQ CoP early and talk about assurance early. That helps with certain standards that you might want to apply to, and certain things that you can check. And algorithmic transparency audits, algorithmic transparency reporting standard. That's a good little tool as well, that has a lot of checklists of things that they're going to want you to be transparent about, and so it'd be good to sort of get those squared away as well.
Brilliant, thanks folks. We've got a few questions now for people who are on the call. I don't know if people are happy to ask their questions themselves. It might just be a bit easier with context. So Hazel, I'm going to give you the ability to speak if you'd like to. I don't know if you wanted to pop your question to our panelists. And you can unmute yourself if you'd like, Hazel.
Yeah, I think I've unmuted myself. Thank you, Joe. Yeah, so I work with Health Data Research UK in their training and capacity building team. So I'm interested in how people get into these kind of careers so that I can share that knowledge with our trainees from our various training programs. So I actually forgot my question. Oh, how did you get into this? How did you each get into your AI related role, and were there any specific qualifications?
Yeah, it's so probably I'll say about how I came into this one. Like I was mentioning before, my background is software testing and assurance, and I was already working in the solution assurance team within NHS Digital around for the past 10 years. So when we have set up a project to look at AI assurance and what is the gap and how we can bridge the gap between current assurance techniques and future AI assurance. I was very keen to join the team and lucky enough to be there as one of them. And so that is my background, and I do not have any data science background. So to try and understand deeper into any kind of data sciencey, trickier technical details, we get the help from Ben and Will, who are experts in that area. So probably I'll just give to Ben and Will to talk about how they ended up here.
Yeah, so I'm from a very boring purist computer science, data science background, and then started working for the NHS and came into this. There's sort of perhaps a question behind the question of how much stuff about data science and AI should everyone know, and to what extent should you is it helpful to move into that and gain expertise and qualifications in that? To what extent should you just know some stuff? I don't have an answer to that. I think it's a really interesting question. I've been involved in various bits of data science training for people in various roles, clinical staff and technical assurers as well. And I think people who have come from a clinical background, who I've met, who have sort of made this transfer into the AI space, add a lot of value. So that was one.
I'll go last. So I studied physics at university and then joined NHS England, or NHS Digital at the time, on their graduate scheme, and kind of went down the data science route. Some things that NHS England data science do have is we have a lot of links for training. I don't have any links on me at the moment, but maybe I can send to Joe some useful links for some training resources that we've enjoyed in NHS England and the data science team. And then maybe they can be emailed out to you at a later time, if that works, Joe.
Yeah, that's brilliant. Thanks, Will, and thanks, Anusha and Ben as well. And kind of on the subject of links, there was also a question a bit later down from Julian Wyatt asking if we can share links to those regulations and documents that Ben mentioned earlier on. So what we'll do is we'll collate all of those after the presentation, and we can include them in an email after the workshop. So that'll come around afterwards. I can see a couple of questions that are related to a question I had. So kind of putting all these questions together. It was around basically, once a technology passes assurance, how is that then communicated to whoever it is that needs to hear that? Is there some kind of flag or mark? Are there particular bodies like integrated care boards that you interact with?
So we actually work. The current way of communication is through our channel and SharePoint site, and we also work with the external bodies like NICE and MHRA and all the other external regulators. There are also regular meetings within NHS England to communicate what are the projects that we have worked on and what is the future work and how we are doing, and that is within NHS England and outside NHS England on the wider NHS. There are some people who actually work as a bridge between NHS England and the Trust or ICBs or PCN. So we have, again, regular catch-ups with them to communicate on the work that we are doing, what is going on the new AI projects, and what is the type of projects that we have done, what is our findings. So all these things are communicated on various channels now.
Great, thank you. And again, another couple of questions that are linked together. So let me try and merge these into one. Is around the specific example of the analysis of the rules underpinning comments on the NHS UK review website. I guess it's around how you actually decided how to do that analysis. So, for example, the decision to evaluate for literary bias and the approach you took to that. Where did that process come from?
So when we were assuring the rules, something that we do is we interview the developers, and the literacy bias was a gap that we identified. So we realized, whilst they've done some really nice analysis themselves and they've shared the results with us, we noticed that literacy bias, there was a gap. That's why we decided to do that particular piece of analysis on literacy bias. We noticed that it hadn't been done already, and well, I think that hopefully answers the question before I go into more detail.
Yeah, thanks. I guess in kind of general terms, maybe not the specific example, but if you're just evaluating assuring generally, how does that process happen? Is it through that stakeholder engagement?
Oh, go on, Ben's.
Yeah, I mean, it's a mixture of things. We try and build up these risk logs so that we've got like a base of questions that we'll always ask, and that gets more and more comprehensive as we work through. So that kind of keeps us right and make sure that we're, because it's one of these problems of how do you ask everything? Or you make lists and then you make them bigger. And I guess the other elements to that are, we started with stuff from National Innovation Centre for Data, who said these are particular risks that you want to start off on. Some of it's looking at the priorities of the team. So they say, these are the kind of things that we're most worried about. How can we be sure about these things? I think literacy bias came up, and other things came up there as well. And then another way that we, for bias, we took an approach of saying, well, there's 9 protected characteristics. Let's add postcode on there. Let's have every intersection of those. That's 45 categories. Let's try and ask a question of every one of those. You often find that in most of those cases, you have no data for them. But at least you ask the question, you say, we have no data, and then you say the risk remains. And you said something.
I just also wanted to add that I think Ben, as I came out of mute, Ben covered that already, the bias, but just wanted to add that we look for existing best practices or guidance that is already out there. So on the bias, we looked at the Equality Act and what is it suggesting to do, and that is how we came up with those protected characteristics. And also from the wider studies that is out there, we have picked up postcode as one of them needs to be added.
Great, thanks folks. So I'm aware we're 2 minutes away from time, so perhaps just one last question to bring us into land. Are there any, or is there like a main reason why technologies fail at assurance? And I guess linked to that, what would your main take-home message be for all of our attendees today?
I always have this one, which I hammer on, which is that most of the sort of AI horror stories that you've read about in the papers, I think, could have been stopped by someone asking basic questions early, often basic questions of the training data. So they've been found to be biased in some way. And if someone had asked a pretty basic question about what it was trained on, they would have noticed it a long time ago. And so that would be my application, I think.
Yeah, just to, if I can just add on that, is like, even if we're not considering the AI, if we just think of the traditional assurance, so any kind of testing around a basic system that usually covers some of the things that can terribly go wrong, even if it is done by somebody who doesn't have an AI knowledge.
Fantastic.
I'd then
Well,
contradict what I say by saying that AI assurance is really hard. There's limits to it. You're never going to do it completely, but that doesn't mean that there's not value that can be added in the space. And yeah, that's what I think.
Great. So we shouldn't let perfection get in the way of the good. We can make improvements even if it's not perfect.
Absolutely.
Great. Well, thanks so much, folks. We're coming right up to the hour now. So all that's left to say is thank you to our speakers, Anusha, Ben, and Will. We really appreciate the time you spent with us today. As I mentioned, the recording of this will be available afterwards, and we'll share those links around to all attendees. Hope you all have a lovely rest of your evening, and we'll see you all for the next webinar. Thank you all so much.
Thank you for having us too. Thanks. Bye.